everybody. The topic of my PhD is the multimodal analysis of functional connectivity changes in post-stroke patients with disorders of consciousness. My name is Danuta Szirmai, and I'm a resident neurologist resident in the National Institute of Mental Health, Neurology, and Neurosurgery. My vision is to have high-quality neurocritical care, and I try to do it by employing electrophysiological methods in neurocritical care. These are my specific goals. The first goal that I have is to assess the prognostic power of EEG connectivity measures in patients with prolonged disorders of consciousness. The misdiagnosis of disorders of consciousness is really high. It can be as high as 38%, which means that 38 people out of 100 get diagnosed as comatose, although they show some covert signs of consciousness. The most challenging differentiation is between the unresponsive wakefulness syndrome and the minimal conscious state, because these patients look wakeful, but they do not show awareness. And here comes the importance, because the misdiagnosis results in suboptimal treatment and treatment withdrawal in this patient group. And that happens after withdrawing treatment for a new complication in more than half of the cases. So there is an obvious ethical and clinical reason for accurate biomarkers to predict the recovery of these patients. There are different methods to assess the state of these patients, such as clinical scales, electroencephalography, so EEG and EEG connectivity measures, and neuroimaging methods. And they can be used as predictive factors as well. But the question is, which of these methods is the best to predict the recovery of these patients? So our aim is to compare the prognostic value of EEG connectivity measures and clinical measures in this huge arsenal of different diagnostic techniques for disorders of consciousness. Our clinical question is, can EEG connectivity measures improve the prognostication of patients with disorders of consciousness if we compare it with clinical measures? We would examine adult patients with disorders of consciousness, and our hypothesis is that connectivity measures are doing better or much better than clinical measures that are used most of the time in this patient population. We hope that our study will help the clinical and rehabilitative decision-making and also help the communication with the patient's family. I conducted my systematic search with a pretty wide search key, not to miss anything. And I have, at the end now, 5 eligible full text. We had some problem after the full text selection, since the data included in the articles was not poolable, so it seemed like that we cannot conduct a meta-analysis. But we sent out emails with data requests, and within 1 week we got back 2 responses. I put a little heart next to the author's name who responded, because probably it's because of them that we are able to do our meta-analysis finally. So I did my risk of bias assessment, and we are doing the figures and tables now. My second project is an EEG connectivity-based prediction system of outcome after aneurysmal subarachnoid hemorrhage. This is a plan of a protocol of an observational study. Spontaneous aneurysmal subarachnoid hemorrhage is a very important disease because it affects mostly employable age people aged between 40 and 60 years. And it's a severe disease with a mortality rate up to 35%. Approximately 1/3 of the survivals remain severely disabled, not only because of the bleeding, but also because of the secondary complications that happen after the hemorrhage, such as delayed cerebral ischemia and vasospasm. It is a large healthcare burden, but if these secondary complications are detected in time, then it can lead to better clinical outcomes for the survivors. The current guidelines now for the management and for the outcome prediction are based solely on radiological and clinical measures. EEG is a good device. It's affordable, it's portable, it's non-invasive, so it seems a good choice for this patient population. There are some studies that are using EEG signals for the detection of these secondary complications at an early stage, but none of them using EEG connectivity methods. So our aim is to identify EEG connectivity markers to predict the appearance of the secondary complications such as the vasospasm and delayed cerebral ischemia, and also to predict long-term outcomes such as mortality and morbidity. Our clinical question is if we can use EEG connectivity measures to predict these short-term and long-term outcomes in adult patients with subarachnoid hemorrhage. Our prognostic factors are the EEG connectivity measures such as the calculated phase lag index and minimum spanning tree that I will not talk about further. About the outcomes, I will have the next slide to talk about. We really think that connectivity measures can predict short and long-term outcomes in these patients. We hope that our research will help decision-making about treatment options. It will provide information for the patients and also for the families. And lastly, it will decrease morbidity and mortality in this group. These are the outcomes that we would like to examine. We have short-term outcomes that we will examine in the first 2 weeks after the hemorrhage. The delayed cerebral infarct and the vasospasm that I talked about. We have long-term primary outcomes is the 1-year mortality. And after 1 year, we would like also examine the cognitive status of these patients, so the memory and the executional functions, the morbidity of the patients, and the physical independence of them. This is the overview. So the first project contains so few articles that we hope to finish it in the next quarter year, maybe until May. And the second, we try to submit until September next year. Thank you for your attention.
Thank you for your presentation. I would like to ask about your first project that you mentioned that there are these 2 conscious disorders or consciousness disorders, and the treatment, let's say treatment for one of them is withdrawal of care. And what's the treatment or what's the adequate path for the patient with a minimal conscious state?
So no, the treatment withdrawal is a problem in both of the states because that causes the death in most of the cases. So the treatment is just keeping the patient alive that after 1 year or after 2 years or maybe after 3 or 5 years, as I saw it in the article, can regain consciousness or even regain a healthy status. After 5 years, maybe not, but after 1, 2 years, they can really do.
My question is about your second topic. You may pass it because I was wondering whether you only use some kind of standard statistical measures for those networks. You mentioned spanning trees and stuff like that, or can you construct new network measures for the specific goal?
Yeah, we are not planning to perform another one. There are a lot of existing ones, and some of them are better for some other diseases. That's why we conducted the meta-analysis, because these are similar in part of connectivity measures. So we have some ideas to conduct the same on the patients, the subarachnoid hemorrhage patients, for example, the phase lag index that we will use.